Hey guys, it's me, Dr. Sneerman, Gyno Girl. Today I want to talk to you guys about, a few weeks ago I did a talk with Rachel Hughes and Oh Hello Perry about women of color in menopause and perimenopause and some, differences in that. And we need to highlight that a little bit more as it's not discussed as much. We're also going to briefly touch on the New York Times article that highlighted the Mayo Clinic study about the burden of menopause and perimenopause in the work environment. So let's get at it. Okay, hi, I'm Dr. Sneerman. So for those of you that are new to my channel, Gyno Girl on Instagram and Gyno Girl TV here, I advocate for all patients that have uteruses and ovaries entering the midlife, sexual discomfort, sexual pain, and sexual disorders. So anything related to female sexual dysfunction around perimenopause, menopause, pelvic pain, and some general GYN issues, as well as women health issues that come up. If you're new to my channel, I'm a gynecologist, board certified in downtown Chicago with a solo practice with an emphasis on perimenopause, menopause, female sexual dysfunction. I am on the board of the International Society for the Study of Women's Sexual Health, ISWISH. Please check out ishwish.org. And I'm also a certified menopause physician through the North American Menopause Society. So please check out North American Menopause Society or www.menopause.org. That's where you can find other providers or healthcare workers like myself that are really heavily involved in these issues. About 1 or 2 weeks ago, I did a discussion with Rachel Hughes. She's at Rachel Hughes Midlife on Instagram, and the Oh Hello Perry group, which is a perimenopause advocacy group. And we talked about sort of differences in women of color entering menopause and perimenopause. I want to highlight some of the things that we spoke about. And I also want to talk about one of the issues that was highlighted in the New York Times article just recently. And this is what the New York Times article is titled: Study Shows the Staggering Cost of Menopause for Women in the Workforce. What it demonstrated, it was a Mayo Clinic study of over 4,000 women, and they surveyed women about issues that they had around the workplace and the cost, whether or not they had to leave the workplace. And it turns out that it was estimated that it was a $1.8 billion loss in working time per year. Let's emphasize that again. 1.8 billion with the B dollars in lost working time per year, according to this Mayo study that was published this week. They asked women about concerns around their workplace, which I see every day. I mean, you have to think about the midlife patient is one that is often at the pinnacle of their career or trying to rise to the pinnacle of their career. And they're experiencing these changes like hot flashes during the workplace, where they feel hot or cold all the time. Or they're experiencing the brain fog. That's what gets a lot of my patients. It's the issues around you're in the middle of a discussion, or you're making this huge presentation, or you're trying to, get somebody to convince them of what they need to be convinced about, whatever their topic is. Or you're a doctor trying to explain something, and you totally forget what you're about to say. And so that brain fog can have, you look like, excuse my French, an asshole sometimes. Like what, patients are embarrassed. They can't talk about it. The taboo around these symptoms is still very real. So this study looked at that. They surveyed over 4,000 patients in the Mayo Clinic sites. This is the study. Minnesota, Arizona, Florida, and Wisconsin are the 4 Mayo Clinic sites. It says roughly 15% stated that they have left their workplace, cut back on hours because of either adverse work conditions or conditions that were not favorable for them. They were then able to extrapolate what this meant for the cost of patients in the midlife. One of the topics that I wanted to discuss is around the women of color, because Black women tended to have more menopausal symptoms, and higher percentages of Black women and Hispanic women talked about adverse outcomes in their workplace compared to white women, which is no surprise. Because what I talked about during my discussion with the group Oh Hello Perry was that, number one, Black women sometimes experience menopause earlier. If the average age of menopause quoted by the North American Menopause Society, which is a North American group, is 52.4, Black women may experience it almost up to a year earlier, 8 months or something like that. One of the big factors in the SWAN study, the study of women's health across the nations, demonstrated that Black women and Hispanic women and women of color had longer durations of the worst symptoms, which for many people are the vasomotor symptoms, the hot flashes, the night sweats. So if on average, maybe a non-Hispanic white has symptoms for about 6.5 years, the statistic is, between 8 and 10 years for women of color, Black, Hispanic women. So that's longer. And we know that patients that experience that vasomotor symptoms for a longer period of time have higher risk of heart disease. And also, Black women are more likely to enter menopause earlier than white women. So if we have premature or primary ovarian insufficiency, which is 40 or less, we see it at higher numbers for Black women than white women. And that means that you're going to have less cardioprotection, that you're going to have potentially more heart disease, more diabetes, which we already know, like even correcting for lifestyle, smoking, obesity, all of that. Black women experience that at higher numbers. The same can be said for other women of color. If South Asians make up about 25% of the world population, they make up 67% of the world heart disease. And so that's staggering in and of itself. And so if women of color are experiencing perimenopause and menopause symptoms earlier and for longer times, and we know that untreated vasomotor symptoms, the hot flashes and the night sweats, increase your risk of heart disease, what's still the number one killer for women? It's heart disease. And so we're not only, killing women earlier, we're not allowing them to have better quality of life. This can be corrected with the right discussion with the right clinicians. I have to encourage my patients to understand these facts, to know these facts, to find the right clinician, and to find the right help. I mean, a lot of patients can do hormone therapy. Most patients should do vaginal estrogen. We already had a discussion about the risk around persistent urinary tract infections, sexual pain, and all of that stuff, and how it can improve the quality of life. And most women can take vaginal estrogen without worry. A lot of this is thought to be due to the allostatic load or weathering that occurs for women of color. What does that mean? That means the daily stresses, the generational stresses that have happened to women of color are now impacting the quality of their life because of the changes in their genetics that have happened over generations. So yeah, I'm talking about colonialism when it comes to brown women. I'm talking about slavery when it comes to Black women. And these generational things have placed a stress on their system to the point that their cells have changed. And at the level of the cellular changes that happens with weathering and the allostatic load, so that means changes in cortisol, changes in norepinephrine, changes in norepinephrine, all of that has changed sort of their epigenetics. So now you're more susceptible to these epigenetic changes, and this is leading to worsening health and worsening heart disease for patients everywhere. So this allostatic load or this weathering that has occurred for women of color is now impacting their changes in earlier menopause, in longer duration of symptoms. I believe the SWAN study also showed that Hispanic women had more genitourinary symptoms. We talked about the genitourinary symptoms that can lead to recurrent UTIs. And then in the elderly population, these recurrent UTIs can lead to sepsis, which again can cause detrimental impact on these patients. We know that implicit bias is there. There is a factor of implicit bias. We know that it exists. And so what's happening is these patients are experiencing implicit bias too because they're being discounted by clinicians as a result of the long history. Some patients aren't even feeling they can trust the healthcare system. That's particularly true for my Black sisters and how over generations they have been misused and abused by the healthcare system. We have to start advocating for our own quality of life and finding someone that will listen to us, and we have to know the facts and know the possibilities of our treatment. That is something I like to emphasize. Implicit bias exists. Your pain, your symptoms might get discounted by the wrong clinician until you tell them that I know that there are treatment options available for me, and I like to have a discussion around my health care and what my history is and what my physical findings are and whether or not you feel like hormone therapy should work? Or is it exercise and diet changes along with that? Or is it, vaginal estrogen? But the discussion should be had, and you should not be discounted. Truthfully, the workplace, we need to make accommodations for patients in the workplace. If we're experiencing this huge loss in wages, some people are quitting their jobs, and these are patients and women that are extremely competent, successful, but they're not getting appropriate care, they're not getting appropriate treatment. Maybe their anxiety levels are really high now that they're in perimenopause and menopause, and they can't function accordingly. There's so much to unravel here, but we need to make sure that as a patient, you're finding the right clinician that can listen to you and that will take your advice and that will have a discussion with you about your medical issues and your history and whether or not treatments that are available are right for you, right? That's number one. Number two, we have to know that there are treatments available. There are ways that we can improve our quality of life. There are ways we can diminish our brain fog, that we can, have less hot flashes and night sweats, to have improved sleep, to have less midsection fat, to decrease our risk of diabetes and heart disease, to improve our sexual life. There are solutions. You have to find the right clinician that will listen to you. And clinicians out there, please listen to your patients, especially women and women of color, okay? Because discounted situations have happened. I hear it every day in my office. The other thing I want to say is we have to start thinking about accommodations for women in the workplace. Maybe it's temperature regulation. Maybe it's allowing extra leave for appointments, for their doctor's appointments, better coverage for medications, whatever the case may be. We need to do better for the patients out there. We need to do better for the patients with ovaries that are very successful in their career, or trying to get to the point where they can be successful in their career, or that are managing their household, balancing parents as well as kids. Whatever the case may be, we need to do better for them so that they can continue to hold the load that women hold on their shoulders all the time, which is caring for everybody and literally their mother and not caring for themselves. That is self-care. Self-care is going out and trying to find how to live a better quality of life. So if you're listening to me, please take my advice. Please go to menopause.org. Find a clinician that will listen to you. And if you're the leader of a workplace, hopefully we'll get some legislation passed here, but we need to do better for the women, the patients out there in the workplace as well. And that's it for today, guys. Please like and subscribe to my channel. More to come, more discussion to come. Oh, the one thing I want to also say is other things that impact the quality of your transition into menopause can be sort of how you've looked at menstruation your whole life. There's some studies that show South Asian patients who historically, maybe by cultural associations, look at menstruation as dirty or unclean or not being able to perform religious activities secondary to menopause. Sometimes those patients have embraced the end of menstruation because they now don't have to worry about if they're clean or not, which is a separate issue. We need to remove that taboo and teach little girls a little bit better too. But removing that, am I clean or not? Can I go to the temple, the mosque, or whatever? There are some studies that show South Asian women that embrace sort of the end of menstruation transition better. So again, we have to be aware of our patients, who they are, how to best treat them, and as patients, we need to know what's happening to our physiology, what we can do about it, and have a discussion with someone who will listen. Above all, if you're a clinician, please take time to listen to your patient. Check your bias at the door, and please take time to listen to your patient. Because most of the time the patients will tell us what's going on with them. All right, that's it for now. Again, this is Dr. Smearman, Gyno Girl. Please like and subscribe to my channel. More to come, more to unravel. Until next time, take care.